Thank you, ISMP Ocon, and thanks to the thoracic DMG for giving me this opportunity. I am presenting our case series of lung cancer with baseline dual EGFR and ALK driver mutations from the thoracic DMG of TMH Mumbai. So definitely we are seeing a lot of new patients where we are finding more than one molecular drivers. Initially it was rare, but the incorporation of improved testing and testing more and more patients, we are finding this is much more common. And now we know that there's very limited data for both EGFR and ALK at the baseline. That is why we are presenting our series of patients with having these co-mutations. So this is a retrospective audit of prospectively collected database, duration of 7 years till 2019. The patients who had concurrent EGFR mutation and ALK fusion was also found. They were included in the study. There was no particular exclusion criteria. The primary objective was to find the overall survival, and secondary objectives to find the progression-free survival, the demographics, pathological features, and the resistant mechanisms. So overall, we found around 24 patients who had concurrent EGFR and ALK mutations, a median age of 46 years, 58% were males. Adenocarcinoma histology in all, one patient had adenosquamous histology. Performance status of 0 to 1 in 67% patient, 2 to 3 in 25%, and performance status of 4 in 8% of the patients. So if we ask what is the method of diagnosis of EGFR and ALK, it was as we do routine RT-PCR for EGFR and ALK by IHC in all our patients. We did ALK IHC, and 24 out of 24 were positive. One patient who had dubious result, FISH was done, and it confirmed that ALK is positive. Then EGFR RT-PCR was done in all these patients at baseline. It was positive. If we ask which was the mutation, exon 19 mutation was found in 67%, exon 21 in 13%. Exon 20 T790 was present in around 17 at baseline, and complex mutations was found in 8% of the patients. So we delivered treatment, first-time treatment in the form of chemotherapy, platinum-based combination in 5 patients, that is 20%. Oral EGFR TKI alone in 29%. ALK-directed TKI alone in another 5%, that is 5 patients, that is 21%. And concurrent EGFR and ALK inhibitor were used in 8 patients, that is 33% of the patients received both EGFR and ALK inhibitor at the baseline, the first line. So this is the results. If we see the overall survival curves, the Kaplan-Meier, if you can see the median overall survival for who received EGFR therapy versus who could not receive EGFR therapy. This is this looking to reach merge with each other. If we see median overall survival who received ALK TKI and did not receive ALK treatment at all due to any cause, it was significantly different, 39 months versus 7 months. So you can see the curves are widely separated from the baseline itself, and it continues to separate for a long duration, and it was highly significant. If we see the overall survival curve based on whether the patient could receive both TKI, EGFR and ALK in concurrent, or received one or none of the TKI, it is again very different. Again, the survival curve you can see 39 months versus 7 months, and it is again highly significant. If we see the multivariate analysis which predicted the survival in these patients, it was the receipt of ALK-directed therapy which predicted that the patient will be having better survival, and the hazard ratio is so low for patients who could receive ALK-directed treatment. We could do NGS in few patients and progression. The number was not very high. We could do in around 8 patients. The mutations identified in a patient was TP53 SMART4 mutations. That is not so common in one patient only. There was grade 3 and higher toxicities was similar in the concurrent EGFR and ALK directed. Grade 3 and higher toxicities were similar in concurrent EGFR and ALK TKI cohort compared with EGFR alone or ALK alone. And we see the PFS of single drug was 6 months, while with combination it was good. But still, to conclude,